Okay, now that we've talked about how the blood flows through the heart itself, now we're going to talk about the actual conducting system of the heart. The idea behind the conducting system is that the heart is actually able to make its own action potentials to cause it to contract, which is a really unique feature it has. It has a couple different structures to identify that the action potential moves through. The first one is called the SA node, which is short for the sinoatrial node. So it's within the atrium. This is the pacemaker for the heart. This is what actually sets up the action potential and initiates it to move throughout the heart. Next, you have the AV node, which is also known as the atrioventricular node. So atrioventricular, going between the atrium and the ventricles. Then after the AV node, you have the AV bundle, which runs between the intraventricular septum. So that's that divide between, again, the atrium and the ventricle. After it reaches the AV bundle, it goes and branches into the right and left bundle branches. These branches move into both the right and left ventricles of the heart, where they then have individual pieces coming off. They're called Purkinje fibers. These are actually cardiac muscle fibers or cardiac muscle cells that then carry the action potential to the actual additional muscle cells within the ventricles, allowing it to be stimulated to contract. So to show the actual process of how it moves through, the action potential will always be initiated by the pacemaker, which is the sinoatrial node, the SA node. When an action potential is initiated, it will cross the atrium, the right atrium, into the atrioventricular node, the AV node. That AV node will then pass the action potential along to the atrioventricular bundle, which will branch into the right bundle, which will branch into the right bundle branch, and then branch into the left bundle branch, going to the right and left ventricles. Then you see off of those branches, we have these little smaller branches, like here, here, and here. Those are your Purkinje fibers. Those are the last piece of the conducting system that's delivering the signal to the actual muscle in the heart. So, like skeletal muscle cells, your cardiac muscle is a muscle, so it does have a resting membrane potential and can conduct an action potential through it. However, it is a little different than the skeletal muscle. So when you learned about action potentials in 157, you learned about these graphs where you have the millivolts on the y-axis and time in milliseconds on the x-axis. And the skeletal muscle, which is right here on the left, has the three phases. It has the depolarization, repolarization, and the hyperpolarization. We're only going to focus on the depolarization and the repolarization phases for this. But what we learned is that when you have the depolarization phase, you have the sodium channels open, and all that sodium comes flooding to the cell. The cell has a normally negative charge, so when we have these positive cells or positive ions flow into the cell, we make it much more positive. We call that depolarization. So during the first phase of the action potential in the skeletal muscle, we have that cell get depolarized until a certain point. Then we have it reach a plateau and those sodium channels close. Then what happens is we have the potassium channels open, and the potassium really wants to leave the cell. So those potassium ions flow out of the cell, so making the cell much more negative. That's the repolarization phase. So that's what this sharp drop is that I'm highlighting here. Then normally that overshoots the threshold potential of negative 85 in this case, and normally the cell has to readjust itself to reach equilibrium again to then have the potential to have a new action potential. All that is information you've already seen from 157. With cardiac muscle, though, it's a little different in that we still have a depolarization phase and a repolarization phase, but we have a middle phase called the plateau phase. And the way the action potential works is that you still have a threshold you're reaching of negative 85. The first phase is still depolarization. We are still having sodium channels open and a bunch of sodium flood into the cells, making it more positive, making it more depolarized. However, instead of it just reaching this plateau and the sodium channels closing and the potassium channels opening, you also have calcium channels to consider for cardiac muscle. So the calcium channels are also opening, and the calcium channels are actually allowing calcium to flow inside the cell, keeping the cell more positive. However, you do also have the potassium channels opening, allowing for some potassium ions to flow out of the cell. So the calcium channels being open, allowing calcium to flow in, is kind of counteracting the potassium channels that are having ions flow out. So you have what's called this plateau phase right here, where we start to get a little bit of repolarization, but not quite. We're kind of leveled off. And then eventually, at the end of the plateau phase, we'll have the calcium channels close, so no more calcium's coming into the cell, and then a bunch more of those potassium channels will open, flooding out of the cell, causing the cell to repolarize, like with skeletal muscle. So the difference in terms of the tension on the muscles itself is that with skeletal muscle, we have the maximum tension right during this repolarization phase. However, for cardiac muscle, we have the maximum tension pretty much spread out over the plateau phase and a little bit of the repolarization phase. This means that the cardiac muscle basically contracts and relaxes entirely during the shaded period. So like I mentioned, by having its own conducting system, the cardiac muscle is what's called autorhythmic, meaning it's able to stimulate itself to contract. And because of the pacemaker cells in that synatrial node, it can generate action potentials by itself. The actual potential that is created by the synatrial node is what's known as pacemaker potential. And this is, again, depending on the movement of sodium, potassium, and calcium, because we're talking about the heart. And much like an action potential you learned about from 157 with muscle cells, you have to have a threshold reached for the action potential to be generated. So this is just a breakdown again of the action potential, but for the heart. So again, with our graph, we have millivolts on the y-axis and time on the x-axis. We have a threshold that needs to be reached for the action potential to occur. And we have the pacemaker potential down here at step 1. This is when we have sodium channels initially starting to open and the cell becomes slightly more depolarized. We haven't quite reached that threshold yet. Once we hit that threshold, the sodium channels rapidly open and we have a lot more sodium flowing into the cell. Depolarization just like normal, just like in skeletal muscle. However, we do have calcium channels open as well during the depolarization phase, allowing for a more gradual drop as the potassium channels open and potassium starts to flow out of the cell. This graph doesn't highlight the plateau phase quite as well, but normally it'd be a much steeper drop if we were looking at skeletal muscle. But this right here would be the plateau area. Eventually, though, those calcium channels again will close, and we'll have that repolarization phase where the potassium channels open, a bunch of potassium flows out of the cell, and then we hyperpolarize again and have to wait a little bit for the cell to be able to do a new action potential. And this period of waiting between action potentials is called the refractory period. So it's when the heart has been stimulated, it's had an action potential, but it can't yet have a new action potential. It's in a sort of recovery period. And the refractory period is broken down into 2 smaller refractory periods. We have an absolute and we have a relative. The absolute refractory period means that the heart in no way, shape, or form can have a new action potential. It's completely desensitized to being stimulated again, to having another action potential. Then the second portion of the refractory period is called the relative refractory period. This means that it is, it can still have some sensitivity, but just very reduced. So in order for a new action potential to occur during the relative refractory period, there has to be a greater stimulus than normal to produce that action potential. Otherwise, if we don't have that, we have to wait until the refractory period is completely over for a new action potential to be launched. And if we have really long refractory periods, this prevents what's called tetanic contractions, which basically means that, unlike your muscle cells, the cells can't keep contracting over and over and over again. Otherwise, if that occurred, the heart would never be able to pump any blood anywhere. It has to be much more rhythmic. So this translates into a tool that we use in medicine called the electrocardiogram. Most of you are probably familiar with this from TV shows. You've seen patients in hospitals with a little green window next to them and the little green line that goes boop, boop, boop. That's an electrocardiogram. What that is we're actually graphing, in a sense, the action potential of the heart and breaking it down into pieces for each section of the heart. So if we look in this graph over here, again, we have millivolts on the y-axis, so that's the charge, and then we have time in seconds on the x-axis. We have a couple different pieces of the electrocardiogram. So we have the P wave, which is this green section right here. We have the QRS complex, that's the spike right here. And then we have the T wave right here, that's in blue. So with the electrocardiogram, we start with a P wave, which is when our atria, that's where blood starts, is depolarized. We then have the ventricles get depolarized during the QRS complex. And then during the T wave, that's when the ventricles get repolarized. You don't really see the repolarization of the atria in the EKG because it occurs over such a small period of time during the QRS complex that it's not really picked up by the machine. But additional things to point out, we have two specific intervals we can look at on the EKG. That is the, excuse me, that is the PQ interval, and that's basically when the atria contract and relax all during this interval. And since during the QRS complex, that's when we have the ventricles get depolarized, that's when they start to contract. So the very end of the PQ interval is when the ventricles begin to contract. Then the rest of the electrocardiogram is the QT interval. So that means, or that phase represents when the ventricles continue to contract and relax. So we're getting the entire contraction with the QRS complex, and then the relaxation with the T wave. So with the action potentials and everything getting depolarized and repolarized, the entire process of this pumping process of relaxing and contracting is called the cardiac cycle. And we refer to one cardiac cycle as one contraction and one relaxation. And the technical terms for contraction and relaxation are systole and diastole. The systole refers to the contraction of any of the heart chambers, and then diastole refers to the relaxation of any of the chambers. So one systole and one diastole is a cardiac cycle. And the thing to remember during the cardiac cycle is that the blood is always going to want to move from high pressure to low pressure. So when something's contracting, it's contributing a lot of pressure to a system, so it's going to want to move away from that contraction. So the high pressure is where the muscle's contracting, low pressure is an area that's relaxing. So it's always going to want to move from a contracted area to a relaxed area. So we'll go through each step now. So 5 portions we have for the cardiac cycle. The first one is the atrial systole and the active ventricular filling. What this means is that our atria, looking at our right atria and our left atria, are going to contract, so they're going to squeeze from that action potential that the heart muscle has been given. And our AV valves, so our tricuspid valve and our bicuspid valve, are going to open because blood's going to want to be moving through those canals. The ventricles are going to relax completely during this time, so blood can move from the atria to the ventricle. And then during this time, those semilunar valves, so your aortic semilunar valve and your pulmonary semilunar valve, are going to want to close. Then we have our ventricular systole. So this is broken down to 2 smaller steps. The first one's called the period of isovolumetric contraction. And what that means is that our atria now are relaxed because they just pump blood into the ventricles. And they're relaxing so they can fill with new blood. Then our ventricles, so our right ventricle and our left ventricle, are going to now contract and cause those AV valves, so your tricuspid valve and your bicuspid valve, to stay closed because we don't want any backflow of blood from the ventricles to the atria. Then during the second portion of the ventricular systole, this is the period of ejection, you're going to have those ventricles continue to contract, continue to squeeze really hard, increase that pressure, And that's going to push the blood out from the ventricles, from the left ventricle into the pulmonary trunk through the semilunar valve, and from the left ventricle to the aorta through the aortic semilunar valve. Sorry, I got mixed with directions there for a second. Your AV valves then are still going to remain closed because we don't want any backflow of blood from the ventricles to the atria. Okay, now we're on the fourth step of the cardiac cycle, and this is the ventricular diastole. And this period is this again is broken down into two periods. This is the period of isovolumetric relaxation. So the ventricles just pump blood, and now they're going to relax. So these semilunar valves, such as the pulmonary semilunar valve and the aortic semilunar valve, are going to close. They're going to clog up so that the blood can't flow backwards from the pulmonary trunk into the right ventricle, or from the aorta back into the left ventricle. And then those AV valves are still going to remain closed during this time. So both the tricuspid and the bicuspid will stay shut. And lastly, for the ventricular diastole, we have passive ventricular filling. So our ventricles are still going to relax, and those AV valves are now going to open. So the tricuspid and the bicuspid valve are going to open, allowing more blood to flow from the atria to the ventricle. And then those semilunar valves are going to stay shut during this time. So pulmonary semilunar valve stays shut, atrial semilunar valve stays shut. So during the cardiac cycle, we have heart sounds that are produced. The sort of colloquial interpretation is that we have the sounds called lub-dub. Lub refers to the first heart sound. This is during the systole, during the period when the ventricles are contracting. And this is actually caused when the atrioventricular valves and any fluid that's around them actually close. So that shutting noise you hear of those valves, the bicuspid valve, the tricuspid valve, that actually produces the lub noise of the heart. And then the second heart sound is the dub. This is when the ventricles relax or have a diastole. And this actually occurs when the aortic and pulmonary semilunar valves are closing. So the actual lub-dub noises are the valves closing themselves.